This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Decay. Want to know what poison causes septic shock? What famous scientist died after exposure? And what medical treatment requires a doctor's note to get through airport security after receiving it? Listen to find out. Today's episode starts in a hotel room. You've agreed to help a friend who started a concierge medicine business catering to patients who need a doctor while staying in fancy hotels in New York City. He's a former colleague who, after suffering moral injury, i.e. burnout, started the business. You agree to cover a few shifts on your days off to help him get the business off the ground. Your pager goes off, directing you to a fancy hotel on Central Park South. A hotel staffer opens the door to a suite with a view looking out over the whole of Central Park. You turn your attention away from the breathtaking view to the woman lying on the couch. Her face is pale and drawn, and her movements are lethargic. You push several used teacups and wine glasses out of the way and sit down on the edge of the coffee table to talk to her. She says she's had diarrhea and vomiting since this morning. She has mild abdominal pain, mostly cramping during the vomiting or diarrhea. She denies hematemesis, i.e. vomiting blood, and denies bloody or black stools. She has no fever or urinary complaints. She says she's 46 years old, doesn't have any medical problems, and doesn't take any medicines. She's a moderate drinker but denies tobacco and drugs. You check her vital signs, noting a bit of a rapid heartbeat at 110 beats per minute. Her other vital signs are normal, and other than the wan appearance, her physical exam is also unremarkable. Given she's here in a hotel, you ask about her travel history. She excuses herself to run to the bathroom. You consider traveler's diarrhea. Returning a few minutes later, she reports she lives in London. She travels frequently for her job as a journalist. She flew into New York yesterday and hadn't been elsewhere for a few weeks, ruling out traveler's diarrhea. She asks if she could have food poisoning. You tell her that, along with a basic stomach virus, is always a possibility. You give her a dose of ondansetron, i.e. Zofran for nausea, and you tell her the rapid heart rate is due to dehydration, and tell her she can either drink to rehydrate or you can place an IV and give her IV fluids. Since both work equally well and she feels better with the nausea medicine, she declines the IV. You prescribe ondansetron and tell her she can take over-the-counter antidiarrheal medicines like loperamide as needed. You give her instructions to go to the emergency department or to seek other medical care if she gets worse. She laughs and says she certainly didn't come to the United States to visit the emergency department and is sure she'll recover in a day or two, though the illness is wreaking havoc with her work schedule. You update your friend in case she requires further medical care. He says he'll have someone check on her tomorrow. 2 days later, you're working in the emergency department. Your resident presents the case of the patient in room 5, a person with vomiting and diarrhea, concluding they likely have gastroenteritis, the medical word for a basic stomach virus. You enter room 5 and are surprised to recognize your patient from the hotel room. Quite frankly, she looks horrible. Before she was pale, now her skin has a sickly gray-green cast. She tells you the symptoms have gotten worse. The diarrhea has increased to the point of incontinence of the liquid stool. Her abdominal pain is now severe. She continues to be afebrile and nothing else about the history has changed. She took the ondansetron and the loperamide as you advised without relief. She says she didn't want to come to the emergency department under any circumstances, but is so weak she can't walk. The hotel staff, in fact, was helping her walk the few steps from the bed to the bathroom. Her temperature is 98.5 Fahrenheit or 36.9 Celsius. Her heart rate is 130 beats per minute, faster than before, and her blood pressure is 90/60, low. Her respiratory rate is 18 and the pulse ox is 100% on room air. You examine her, noting diffuse abdominal tenderness, but otherwise her exam remains unremarkable. Your resident already ordered basic lab work, IV fluids, and nausea medicine. You tell her you'll also check a CT scan of her abdomen as a precaution, though honestly you don't expect to find much. You leave the room feeling unsettled. Is this food poisoning or a stomach virus? It's definitely possible, but why is she so ill-appearing? And worse, despite your previous very reasonable medical care. Norovirus is always a consideration. This is the diarrheal illness that causes outbreaks on cruise ships and schools. It makes patients feel terrible. The treatment is supportive care, as we're doing. We can't really check for this in the ED, but you do tell your resident to add on a C. diff test and some other stool studies checking for common bacterial and parasitic infections. Those are things we can test for. C. diff is the infection you can get from the hospital or from antibiotic use. We don't typically send other stool studies from the ED because the results take days to a week to come back. But given that our patient doesn't look well, it's a good idea to expand the workup. An hour later, you review her lab results. Her creatinine, the kidney function, is elevated, likely due to dehydration. Her liver function tests are moderately elevated. Etiology is not clear, but it isn't uncommon with viral infections. The really unexpected result, though, is her CBC, the complete blood count. Her red blood cells and her platelets are low, not dramatically so. Her white blood cell count, on the other hand, is low, dangerously low. Question number 1. Which of the following can cause a low white blood cell count? A. Malaria, B. Lupus, C. Chemotherapy, D. Sepsis, or E. All of the above? The answer is E. All of the above. One of the main features of malarial infection is fever, which she doesn't have. She didn't suddenly develop lupus with no other symptoms. This could definitely be sepsis, and while we don't have a source of bacterial infection at the moment, I'd cover her with broad-spectrum antibiotics. In fact, the way the CBC looks, I'd think she's getting chemo, except she isn't. Chemotherapy suppresses the immune system, causing neutropenia, a white blood cell count so low patients can't fight off infections, and the reason neutropenic fever is a true emergency. Honestly, these results raise more questions than they answer, and they won't be answered in the ED. She needs admission for continued IV antibiotics until the source of this problem is found. Her CT scan comes back negative, as you expected. The C. diff is also negative. The hospitalist meets you at your desk to hear about the admission. He points to her name on the screen, and he inhales a surprised breath, saying, "Do you think she's been poisoned?" "What?" you ask. He points to her name, saying, "You don't know who she is?" The journalist and a Russian dissident. She's published several scathing articles detailing crime and corruption in the current regime. He laughs and shrugs. "Well, it's probably not that interesting. Just another boring case of diarrhea. We'll admit her and see how she does." The charge nurse calls you into another room, and the busy shift continues for another few hours. Finishing up the charts at the end of your shift, you have time to consider the information from the hospitalist. Could she be poisoned? Anything is possible, but common things being common, it's not at the top of the list. Not to mention, as we've discussed in the past, the differential diagnosis for vomiting and diarrhea is just about any substance on the planet, medicinal, poisonous, or otherwise. You open her chart, scan over it again, and make a mental note to follow her hospital course over the next few days. 2 days later, you go to see her upstairs. She's now in an isolation room in the ICU. Clumps of long blonde hair are all over her pillow. Her scalp is visible in places. Question number 2. What is the medical term for this problem? A. Matarosis, B. Alopecia, C. Hypertrichosis. The answer is B. Alopecia is the term for hair loss. Matarosis is the loss of the eyelashes or the eyebrows. And hypertrichosis is too much hair growth. So the patient talks to you and answers your questions, reporting the diarrhea continues unabated. She's really sapped of the sparkle and humor she displayed in the hotel room. And that's not the only thing getting worse. Her liver and kidney functions are worsening. It's doubtful now that this is due to dehydration because the copious amounts of IV fluids haven't improved her creatinine. Her white blood cell count is now officially low enough that she's neutropenic. In fact, she looks like an end-stage cancer patient getting chemo. Hair loss, weight loss, intractable vomiting and diarrhea, with an immune system that can't function. Maybe the hospitalist is right. You don't need me to tell you this is way too much for a stomach virus. Either she has an undiagnosed rare disease which the hospitalist can't find, or in fact, she is being poisoned. You return to a computer to comb through her chart. Her red blood cell count and platelets are now very low too. This is bone marrow suppression. If you remember, your bone marrow makes the cells that circulate in your bloodstream, red blood cells, white blood cells, and platelets. Various diseases and toxins can cause problems with each cell line, but when all the cell lines are down, this is what we call bone marrow suppression. Chemo, as I mentioned, is a big culprit. Bone marrow cancer can cause it, in other words, leukemia or lymphoma. There are rare hereditary diseases, though that's not very likely in her case. Thank goodness we have oncologists. I could never do their very difficult jobs. But this is a toxicology, not an oncology podcast, so let's get right to toxins causing bone marrow suppression. At this point, it's really the key feature of her illness. As I said, chemotherapy drugs would be 1 through 100 on any list, but no chemo here. Drugs for autoimmune disease like lupus and rheumatoid arthritis can certainly suppress the bone marrow. For example, quinidine and gold. Yep, gold salts are actually medicine. The classic drug is chloramphenicol, an antibiotic we rarely use thanks to this disastrous side effect. Another classic is clozapine, the antipsychotic, again, rarely used for the same reason. Antihelminths or deworming agents like albendazole can cause it. These drugs honestly are rarely used in the US or Western Europe. We do occasionally see cocaine contaminated with levamisole, that's a veterinary deworming agent. Occasionally antiepileptics like carbamazepine, though this is pretty rare. Drugs to treat hyperthyroidism and tuberculosis can cause it, but our patient doesn't take any medicines and she isn't using supplements. So, where does that leave us? One possible cause comes to mind, and that's question number 3. Time to pick your poison. This could be A, radiation, B, pesticides, C, microplastics, or D, tobacco. The answer is A, radiation. How would she be exposed to radiation, did I hear you ask? Excellent question. We use radiation as medicine. There's a whole specialty called radiation oncology for cancer patients. We use radioactive isotopes in nuclear stress tests for heart disease. Thyroid disease also can be treated with implantation of radioactive pellets. In fact, if any of these patients travel, they require a special doctor's note because they'll set off radiation detectors in airports and other places like the Super Bowl. It really doesn't make patients sick, even though the radioisotope used in cardiac stress tests is radioactive thallium. The patient hasn't had any procedures. Still, I 100% want to check for radiation. How? Unlike most toxicology testing, it's simple. Most hospitals have Geiger counters. 1, because hospitals contain radioactive isotopes, as I said, and 2, after 9/11, many hospitals wanted one on hand for emergency purposes. You make some phone calls to locate the Geiger counter. Nobody seems to know where it is, but several people promise to look for it. In the meantime, let's talk about radiation poisoning. Question number 4. Who discovered radiation poisoning? A, Marie Curie, B, Albert Einstein, C, Nikola Tesla, or D, Max Planck? The answer is A. Marie Curie essentially discovered it in the late 1800s, along with her discovery of X-rays. That said, of course, understanding of its effects developed after her exposure into the 1900s, and it wasn't until 1946 that acute radiation syndrome was first described by the U.S. Army Medical Corps, treating victims of the Hiroshima and Nagasaki nuclear bombs. 4 stages of radiation poisoning are described. First, nausea and vomiting, beginning anywhere from hours to days after exposure. Second, sometimes there's a latent stage where the patient appears to improve. This is followed by stage 3, severe illness, and if the patient is lucky enough, stage 4, recovery. The stages can take hours to weeks depending on the dose of exposure. The third stage is really the bulk of what we think of as radiation poisoning, and it consists of a number of different problems comprising what are called subsyndromes. To briefly summarize, patients can have cerebrovascular problems, including weakness, seizures, and coma. Pneumonitis and lung injury can occur. The skin can blister and desquamate, meaning peel off. Hair and nail loss can occur. GI symptoms, including vomiting, diarrhea, and abdominal pain, are very prominent. Why? Gastrointestinal cells are the most rapidly dividing in the body and therefore show the effects of radiation most quickly. In fact, the whole mucosal lining of the GI tract can slough off, allowing bacteria into the body and causing secondary infections and sepsis. This brings us back to the immune system, which is actually the most impacted by radiation exposure. The white blood cells are most affected, but complete bone marrow suppression isn't uncommon. If the patient develops infection from loss of the GI mucosal or skin barriers, they have no immune system to fight off sepsis and overwhelming infection. Question number 5. What lab test is the best predictor of radiation exposure? A, the red blood cell count, B, the platelet count, C, liver function tests, or D, the white blood cell count? The answer is D, the white blood cell count. There's something called the Andrews nomogram, and I love this graph because it's a case where a picture is worth 1,000 words. It's a graphic depiction of a dose-response curve predicting severity of poisoning. The higher the dose of radiation the patient is exposed to, the more quickly their white blood cells drop. Using that graph, if our patient is indeed suffering radiation poisoning, she is in a category of severe injury, given how quickly her white blood cell count dropped after the onset of her symptoms. Acute radiation syndrome describes the clinical effects on the patient, but what is the radiation actually doing? It has both direct and indirect effects. It directly damages DNA inside cells. Acutely, this can kill the cell, and indirectly, it causes formation of free radicals from water, for example, which also damages the cells. These are the complications related to acute radiation exposure. As I'm sure you know, exposure is a risk factor for cancer, and this is a chronic effect. Scarily enough, radiation is considered a universal carcinogen, meaning it can cause almost any type of cancer. Why? Because radiation causes breaks in DNA. Back to our patient. A man in the engineering department finds the Geiger counter and brings it to the ICU. You scan the patient. Nothing. Not even a blip. You check a YouTube video to make sure you're using the thing right. It's not rocket science. Turn it on, wave it around, and listen for the clicking sounds. You do this several times. No clicking. None. You heave a sigh of relief. If the patient had radiation poisoning, she'd have contaminated the hospital room, the other patients, the staff, and you. But wait, if it's not radiation, what is it? And why do her symptoms fit best with radiation poisoning if there's no radiation to be found? This type of dilemma is one we physicians spend a lot of time thinking about. We don't want to make an anchoring error, continuing to pursue a diagnosis despite a lack of supportive evidence. On the other hand, we don't want to drop a diagnosis that fits just because we don't have a positive result. That's been called the zebra retreat, backing away from a rare diagnosis just because it's rare. A good clinician can navigate these two uncertainties and plot a course down the middle. Easier said than done, I can tell you. Thinking about this path and our patient, both the hospitalist and the hematologist agree her symptoms fit with radiation poisoning. On one hand, the patient has no exposure history. She wasn't making a dirty bomb, doesn't work in a factory with radioisotopes, and certainly hasn't been mining uranium. The Geiger counter says no radiation. On the other hand, she's a Russian dissident living abroad, criticizing the current regime. If you've listened to this podcast or paid attention to anything in the news, you don't need me to tell you that's a dangerous job. So what do we do? And are you about to get sick? You were in her hotel room, touched her teacups and wine glasses, and sat on her coffee table. I hate to leave you on a cliffhanger, but we've run out of time today, and you're going to have to listen to the next episode to find out. The last question in today's podcast, question number 6. What caused Marie Curie's death, likely due to her lifetime radiation exposure? A, thyroid cancer. B, neutropenia and sepsis. C, aplastic anemia. Or D, hemorrhage. Follow the Twitter and Instagram feeds, both at PigPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pigpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.